Hi everyone, my name is Rich Brock. I'm a fourth year medical student. I put this presentation, it's titled Tips for Succeeding in Your Internal Medicine Acting Internship. And I put it together because there's a lot of information to learn on the spot during your acting internship. And so this is a primer to help prepare you, help facilitate the amount you're learning on the spot, and help kind of give you a foundation for when you're going into it. And ideally, this will help you get your work done more efficiently so you can get out of the hospital early or on time to do those things outside the hospital that keep you well. So by the end of this lecture, you will have reviewed how to, one, effectively chart review and pre-round during your internal medicine acting internship, deliver an organized oral presentation, develop a concise and thorough assessment and plan, and thoroughly and effectively interview a new patient and write a history and physical. So, welcome everyone to the fourth year of medical school. It's a mix of a lot of busy times, a lot of relaxing times, depending on the rotation you're on in the time of year. The acting internship for internal medicine is on the busier side. So I hope this presentation helps. And fourth year goes by very fast. So don't get caught up too much in your worries. Things are going to work out well. And I think enjoy fourth year. This is the pinnacle of your medical school career. Depending on your rotation, you might be the primary doctor for your patients, that the one that sees them the most, that answers their questions, tells them how they're doing, what the plan is. So take this responsibility on and get the most out of it. In terms of maintaining your wellness, there's some rotation specific information here that I think is valuable. The rotating call schedule means that you can get out as early as 1 p.m. on some days, even earlier on the weekends. And so if you're not admitting a new patient or actively working on an old patient or waiting for a teaching session, sign out to the residents, go home early. As long as you're not sacrificing the quality of your work, it's not looked upon negatively at all. Make sure you keep on doing the things that keep you well outside the hospital so you can recharge your battery and do well while you're working in the hospital. Make sure you get plenty of sleep, because working 6 days a week on top of everything else fourth year really can wear you out. You've probably heard this before. Internal medicine's like the bread and butter. The bread and butter cases of internal medicine provides a really important foundation for your medical careers. No matter just like history taking, writing notes, organizing your thoughts, presenting patients, no matter what future specialty you're going into, whether it's surgical or non-surgical, you're going to be using these very similar skills. And so, this is a really important rotation to take advantage of to prepare you to apply very similar skills to those specialties that you go into. So in terms of, starting your day, I think in essence, do what you need to do to be well. For me, that was, really sleeping early to wake up early for these, long hours, or at least early hours, and, have some breakfast, bring some breakfast to the hospital, whatever, just get into a routine so you can wake up refreshed and get into the hospital and do your work. Your days will start with chart reviewing and sign out in the morning. A brief overview of how to chart review effectively and efficiently. Only spend a few minutes per patient. If you're spending much longer than that, you're probably not doing it efficiently enough. And those few minutes will depend on how much happened overnight. And how much active stuff is happening to your patient during that time. But a good framework of how to get through patients that you're reviewing and following and managing are, start with notes from overnight. see what the nursing staff was saying about your patient, see if any consultants dropped any notes or recommendations about your patient, then go into vitals. Was the patient febrile? Did they require any oxygen? Hypotensions, things like that. Then go into the medication administration record, or the MAR. Were they receiving any new medications? Are there any medications being consistently declined? Did any antibiotics expire that need to keep on going? Things like that. And then check inputs and intake and outputs. If you're tracking these for reasons like diuresis or kidney injury. If you're not tracking these because you don't really care for your patients, you don't really have to worry about this part. In terms of next is good to go to lab results or imaging. See if there's morning labs in, see if they got any new imaging from yesterday evening or early this morning. And then check miscellaneous things. Were there any like EKGs done? There any micro labs that you've been waiting for, like cultures? You can check the blood glucose and see if they have diabetes and if they're in your range, or if you need to adjust the insulin at all. And then after reviewing these things, or before, or whatever, print your list, go to sign out, and take note of any overnight events that happened for your patients. Pre-rounding, this is where you go see your patients. Check in with them, see how they did overnight, how they're currently feeling. Ask about symptoms that they've been feeling or are related to their condition. So for something like heart failure, ask about breathing, swelling, chest pain, urinating. Are they responding to the diuresis if they're there for exacerbation? And you can keep this pretty focused and concise. You don't have to do a full, every single system, ask about questions. Keep this focused to the things that you're really focusing, that you're treating the patient for, or the patient's there for. In terms of general questions to think about and ask all patients, maybe not every day, but occasionally, are things like pooping, peeing, eating, walking, general things that are necessary for them to continue with their daily life, and if they're going to go back home, if they're going to be able to go back home. And so you'll also want to ask about their living situation. Do they need subacute rehabilitation? Do they need physical therapy? Ask about who they live with, stuff like that. And then if the patient is altered, or if they have really poor memory, you can check in with the patient's contact person or visitor to get an idea of how the patient's doing and how it compares to their baseline. If you ever call a family member or a contact person and you need to leave a callback number, you can tell the person to reach you by calling the hospital. For UVM, that's 802-847-0000, and they'll reach an operator and just tell them to ask the operator for your name and your pager number, and when they call, they can page you. As a cool pro tip that I learned during one of my rotations with Dr. Carolyn Boscia, tell the patients how they're doing and what to expect. And a good framework for this is have a tied up plan. And this is how you tell them, you tell them how they're doing clinically and what to expect. The T stands for trajectory. Are they getting better? Are they the same? Are they getting any worse in terms of their medical conditions? And then go through each of their medical issues and briefly go over each problem that you're managing. Is the status, is it getting better, worse, the same, and what the plan is for each of those issues. E is for expectations. What should the patients expect for that day in terms of like bodily things that are happening to that patient? They're going to get blood draws. Are they going to get imaging? Are they going to get EKGs, physical therapy coming? It can be kind of, we do a lot of things, a lot of poking and prodding without telling patients that we're going to do them. And so, if you're in a room and all of a sudden an x-ray came in and they were going to do a chest x-ray and they didn't know, that can be kind of concerning for some patients of like, why am I getting this chest x-ray and things like that. So it's, it's good to clarify these things. I think patients have the right to know what we're planning to do to their bodies while they're in the hospital. see, talked about that. And then, D in TIDE stands for discharge. You can give a general idea about discharge date if you've talked about it, if you have an idea. Otherwise, you can defer that if you don't.